So now I would like to welcome Dr. Duncan Wilcox to give his Urology 40 Years On talk. Thank you, Dr. Wilcox.
Dr. Bishop, thank you very much. Obviously, it's a great pleasure to give this talk at this 40 years after the transformation of care of patients born with anorectal anomalies. You know, 40 years ago, patients who were born with an imperforate anus or an anorectal anomaly were felt really to have a problem just of the anorectal or the bowel. They were rarely thought to have problems with associated anomalies. But with increasing investigation, we know now that that's not the case. And in fact, when you look at patients who are born with anorectal anomalies, they have a lot of problems that affect the genitourinary tract and the kidneys. About 80% of patients will have some degree of renal anomaly. Although the vast majority of these are mild, many will have problems in which the kidneys have not developed normally, which can lead to chronic kidney disease. And this can affect somewhere between 6 and 12, 15% of patients, depending on the severity of the problem. Up to 40% of patients will have some sort of spinal anomaly. And as we'll talk about later, patients who are born with a spinal anomaly have problems in the way the bladder is controlled, because the bladder is controlled from the lowest part of the spine. And so consequently, lower spinal anomalies can lead to problems in which the nerves are not developing properly, leading to difficulty in voiding. Nearly half of all male and female patients will have some genital anomaly, many of which are easily treated and do not lead to long-term problems. But these combination of renal problems, genital problems, and spinal problems can lead to urinary tract infections in up to a quarter of our patients. They can lead to urinary incontinence, which can be a long-term problem. And in some patients who go into adulthood, some degree of sexual dysfunction. So the role of urology has definitely evolved so that we now are involved in care pre-reconstruction, during the reconstruction, and after reconstruction. So pre-reconstruction, our role is to evaluate the whole genitourinary tract to ensure that patients are not at increased risk for long-term renal damage. We also have a role in trying to prevent urinary tract infections. A lot of patients have a colostomy, but sometimes the distal part, the part that leads to the anus, still contains feces or has feces that spill over into it if the colostomy is not separated from the mucous fissure. That's where the distal part, the last part of the bowel goes. And so consequently, you have urine and feces mixing, which is obviously a very good recipe for urinary tract infections. So it's really important that the colostomy is separated so that feces doesn't spill over. And also that the last part of the colon that isn't attached to the colostomy is washed out regularly so that there are no fecal matter going into the urinary tract. Now, during reconstruction, we have a role in understanding the anatomy, especially using small cameras that can enable us to see where all the different components of the anatomy are. This is particularly important in patients born with cloacal anomaly, where it's useful to see exactly where the urethra, the vagina, and the rectum are. And then sometimes, especially regarding colostomy closure, it's possible for us to do some of the reconstruction of the genitourinary tract, especially genital problems such as penile problems, at the same time, so reducing the number of anesthetics the patients need. Post-reconstruction, our role is really to protect the renal function. Because if you damage the kidneys, unfortunately, kidneys don't repair themselves. We're involved in treatment of continence and later genital problems. So the reasons for worrying about urology are to treat urinary tract infections, to minimize the chances of going on to get chronic kidney disease, to manage incontinence, especially in patients who have a high pressure system that can damage the kidneys further, and to look after both genital and sexual dysfunction, especially in boys. So in terms of protecting the renal function, it's really important that we minimize urinary tract infections. And that is because if you have a urinary tract infection, especially one that is symptomatic, that can lead to problems with new scar formation or new damage to the kidney. And that scar will eventually, if you get more and more scars, lead to chronic kidney disease. Patients are more at risk to getting new scars in the first year of life, and they're more at risk if the urinary tract infection goes untreated for about 48 hours. So that's why in the first year of life, we're particularly vigilant about urinary tract infections, and why later on, we care about treating with antibiotics quickly. Other things we can do is we can treat the constipation, or we can give prophylactic antibiotics, and we can manage any congenital renal problems. Probably the most important thing we do, though, is to improve the bladder mechanics. If we look at all patients who are born with anorectal anomalies, about 83% of them, about 83% of them will have some sort of abnormality of the urinary tract. And that can be renal anomalies, anomalies of the renal position. It can be the fact that the ureters are not entering into the bladder, but entering outside of the bladder, which can lead to problems with incontinence. It can lead to vesico-ureteric reflux, which often doesn't need to be treated, but in severe cases does need to be treated. And this can go on to problems with chronic kidney disease. If you look at the renal anomalies, all sorts of renal anomalies can occur. So patients can have renal dysplasia. This is where the kidneys have not formed properly and are not large enough. They can have solitary kidneys or kidneys in which the kidney is not formed and doesn't work at all. The most common ones, though, are related to hydronephrosis, either hydronephrosis in a single system or in a duplex system. In patients who have hydronephrosis, we manage these patients in exactly the same way as we manage other patients who don't have anorectal anomalies. That is, we get an ultrasound scan, and in those with a more severe degree of hydronephrosis or dilatation, we get a MAG3 renogram, which tells us what the function of the kidney is and how the kidney drains. And in addition to that, we get a VCUG, which is a way of looking for reflux. Most of these patients will get better on their own and don't require any surgical intervention. But about 20% of patients will require some sort of intervention in the first 2 or 3 years of life. So typically we observe these patients with regular ultrasound scans. Despite our best efforts, about 6% or about 1 in 20 of all patients born with an anorectal anomaly will develop chronic kidney disease. And the more severe the anorectal anomaly, the more likely they are to need renal replacement therapy, such as dialysis or renal transplant. And up to 50% of patients who are born with a cloaca will end up with some sort of chronic kidney disease in their life. So it's critical that we address these issues early so that we can minimize the chance of going on to chronic kidney disease or to delay as long as possible the start of chronic kidney disease. So what are the risk factors for incontinence? The biggest risk factor is spinal anomalies. And as we've seen, somewhere between 25 and 40% of patients who have an anorectal anomaly will have some defect in the spine, usually the lower spine. As I've mentioned, the nerves that control the bladder come from the lower spine. And if they've been damaged, this can lead to what's called a neurogenic bladder. Unfortunately, a neurogenic bladder is not one entity. What it means is the nerves of the bladder are abnormal, and this affects how the bladder works. And in essence, this can result in two things. If the control mechanism is strong and doesn't relax, then the bladder contracts and generates high pressure, which can lead to incontinence and damage to the kidneys. If the control mechanism is weak and open, then patients have a low pressure system, which is very safe to the kidney, but can lead to problems with constant incontinence. The more severe the problem, the more likely you are to have incontinence. And if the bladder neck, which is the control mechanism, looks open on investigation, that can lead to problems with incontinence. Frequently, problems with constipation can lead to incontinence, and this is why we tend to get the bowel management treated first before we start managing urinary incontinence, because in many patients, urinary incontinence will go away once the constipation is controlled. But if we look at patients who are between 5 and 10 years of age, many of them will have some sort of incontinence, with even the most simple problem having about a 10% chance of incontinence, with the more complex patients having somewhere in the region of 30% of them having some degree of incontinence. So how do we manage this? The first thing is to understand exactly what the problem. Are these patients who are voiding infrequently and so consequently really stretch and test the bladder? And so we ask questions and get voiding diaries to see how frequently people are voiding and how well they void. Through simple tests we can do in clinic, we can see how the voiding is done, whether it's coordinated. That is, does the bladder relax, does the sphincter relax and the bladder contract at the same time? And in a few patients, we need to do a more invasive investigation, which we place catheters, and this leads to a cystometry. To manage the voiding dysfunction, we have a few options. In patients who can void, obviously we don't need to do anything. If they have difficulty voiding, then sometimes through physical therapy or medications, we can help them void to completion in a regular way. In those patients who find it difficult to void to completion regularly, it's necessary to initiate catheterization. And this can either be through the urethra or through some sort of channel that we create, a so-called mitrophenol. If we do it through the urethra, children often need to have little sensation, or it's difficult to persuade them to do it. And in some children, especially the boys, where the rectum used to go into the urinary tract, the fissure, that can make it difficult to catheterize easily. And sometimes we need to use special, slightly curved catheters to ease catheterization. In the majority of patients, though, if we start early and have a well-organized plan, we can teach families and then patients to catheterize urethra. If the bladder and the sphincter do not coordinate so that the bladder is pushing against the fixed, closed sphincter, then there are a number of things we can do. We can use physical therapy, which works very well, even in some patients who have neurological problems. We can use medications such as alpha blockers, and more recently, botulinum toxin can be injected into the sphincter. This unfortunately frequently requires repeat dosage. In terms of storing the urine, if the bladder is under high pressure, then there are medications like oxybutynin which can relax the bladder, but unfortunately can lead to further problems with constipation. We can also inject botulinum toxin, which is very effective, but unfortunately needs to be repeated every 6 to 9 months. Or we can do bladder augmentation. If we do bladder augmentation, one of the problems is frequently stones, and we manage that by regularly washing the bladder out to try and minimize stone formation. But if there are stones, usually we can remove them through the camera, or occasionally we need to open the bladder to remove them. So when patients transition to adulthood, they can still have problems with incontinence, and that's something we need to manage. They have erectile and sexual dysfunction, and sadly, a few have problems with infertility. So if we look at adult incontinence, these are patients who are born and are over 18 years of age. You can see that about 60% of the patients have no problems with incontinence. But unfortunately, about 20% or 2 out of 10 patients will have incontinence every day. How they manage their bladder, about 3/4 of these patients are able to void on their own and still be dry. But 25% need some sort of catheterizable conduit, either through the urethra or through the mitropony. So clearly incontinence is a long-term problem that we need to address and transition into adult care. We look at male anomalies. As I said, about half of them will have some sort of genital anomaly. The vast majority of these are quite minor, undistended testicles or minor penile anomalies that frequently can be repaired in the first year or so of life. One of the problems that is commonly seen in young men who have anorectal anomalies is they can have problems with testicular torsion or epididymitis, that is severe testicular pain. In adults who are not having anorectal anomaly, testicular pain is frequently caused by testicular torsion. But in patients with anorectal anomaly, epididymitis, that is inflammation of the epididymis where the sperm will go, is much more common than in other men. And so consequently, this is something we need to be very careful about and make sure we exclude before taking patients to the operating room to fix their torsion. Long term, men can have problems with erectile problems, especially if they have a spinal problem. But fortunately, with medications such as Viagra or prosthesis, we're able to correct these erectile problems. Ejaculatory problems are very frequent. Typically, men cannot generate enough pressure, so the sperm come out quite slowly, or sometimes the sperm go back into the bladder. This is a problem that can be fixed for fertility, but obviously is unsatisfying for men and not to have a normal ejaculation. Men, however, can be fertile. In the 30 men that we looked at, 11 men had conceived, had partners who conceived, but 4 of those required in vitro fertilization. Because of these problems, we feel it's necessary to follow up our patients through potty training or until social incontinent. Make sure they have normal renal function, normal bladder function before they discharge, which means that a lot of our patients, probably half of our patients, are continued to be followed up by urology well into adulthood. So in conclusion, why worry about urology? We want to worry about urology so that we can prevent renal damage. We want to reduce urinary tract infections, which can lead to further renal damage. We want to make sure we maximize the chance of normal continence and help those patients in their adult life with sexual dysfunction. Thank you very much.